I'm pleased to welcome you this morning. My name is Suzanne Heckenleibel, and I'm the Executive Director of Delta Dental of Iowa Foundation. Now it is my pleasure to introduce Don Hutchins, who is the President and CEO of Delta Dental of Iowa and the President of Delta Dental of Iowa Foundation. Don has successfully led the company over 13 years to be one of the most leading dental benefits carrier in Iowa. Don is passionate about giving back to the communities we serve, and through his leadership, the foundation was created in 2007 to support and improve the oral health of Iowans. Please join me in welcoming Don Hutchins.
Good morning, and welcome to our Educates session, leading us through a beginning of a process to try and make a difference in the oral health of aging Iowans. I have to say, when I first heard about this idea of holding a conference, I don't think we ever imagined that 180 Iowans would take time out of their schedule on a Friday during the Christmas season to come to a seminar like this. So I want to personally thank you for coming, and we look forward to beginning this journey with you. The Delta Dental, as many of you know, is a nonprofit health services corporation that primarily provides dental benefits to Iowans. We do that through working with participating dentists, purchasing groups, and subscribers who use our services on our dental patients. Our vision as an organization is to improve the health of the people we serve. We do that by investing in what we call a public benefit program, or quite frankly, giving back through philanthropy. And the primary vehicle we do that with is the Delta Dental of Iowa Foundation. Since 2002, when the program started, we're proud to have invested over $13 million in oral health initiatives in Iowa in a variety of venues and with many of the people in this room. This is a significant investment, but we hope to be able to continue to build that investment in the future, and with you make a difference in the oral health of our aging population. One of the neat things for me over the past couple of years is that the foundation has been involved in a strategic planning process, and that resulted in identifying two long-term goals. They're big goals, and the goals are displayed up here on, and I think you have them in your packets as well. But the goal is for us by 2020 to eliminate caries in every child under 12 living in households with income under the 300% of poverty level. Big goal. Second goal is why this session is happening today. It relates to, by 2020, having every Iowa nursing home resident and home elderly person have access to oral health care. Big goals, hard to achieve, but we firmly believe we have a chance by working with all of you and others who are not able to be here today to make significant progress towards those goals in the next 6 to 7 years. As a result of the goals, the foundation has begun to consciously shift how it invests the programs it works with to try and begin to support these goals. Over the last year, we made good progress with that. We have 4 funding buckets. We call them oral health contributors. They're also on the map here, that we believe are going to help us to achieve them. They're straightforward, and many of you will recognize them. Education and prevention, fluoridation, access to care for underserved children, and access to care for elderly, homebound elderly, and nursing home residents. Like you and many in the oral health care system, we believe that there is a strong connection between oral health and overall health, and that serious untreated infections lead to more serious health issues. We know there is much to learn about the aging population in Iowa and their oral health status, but we believe there's a big opportunity to make a difference. We hope what's being presented today will set the stage for some future initiatives and begin to increase the focus on oral health care in Iowa's aging population. As Suzanne mentioned in your brochure details, this is the first of 3 actionable knowledge sessions around aging in Iowa. The second 2 are called Motivate and Activate, and they will take place early in 2013. The goal of these sessions is to bring together multiple stakeholders to develop and have a strategic discussion about what we can do to advance oral health care models and policies that can eventually be implemented for our aging population. During the session today, you'll receive an overview of the oral health status of Iowa's aging population, get key information on the findings of the Foundation's recent questionnaire on the barriers to oral health care in this population for Iowans, and learn and have a chance to share some best practices related to the oral health of aging populations. Some of the best practices are right here in Iowa, and some are national, and we're pleased to have I think, a pretty exciting lineup of speakers for you today. So on behalf of the Delta Dental of Iowa Foundation, I want to thank you again for taking your time, and I know it's very valuable these days, to come and learn with us. Let's engage and reflect on the data and lessons learned today, and hopefully we can all create some opportunities tomorrow and in the future. It's my privilege, so I'm going to segue and introduce our first speaker, who's Maren Lenhart. Maren is an oral health and aging consultant with the Delta Dental of Iowa Foundation. She's also a full-time dental assistant and an MPH student at Des Moines University. Today, Maren is going to present on Iowa's aging population and their current oral health status. So please help me in welcoming Maren.
Can everybody hear me all right if I'm like this? Everyone in the back, yes? Super. All right, well, welcome this morning. Thank you for being out. I will be presenting the oral health status of Iowa's aging population. We have a full plate in the next 50 minutes. I'm going to give a brief overview of the population, Healthy Iowan Goals, which is a subset of Healthy People Goals, how they started in 2000 and midway in 2010, and how we're pushing forward to goals in 2020, and how the aging population specific related goals. As well, we'll discuss the oral health status of homebound and nursing home individuals, as well as a questionnaire that was sent out by the Delta Dental of Iowa Foundation earlier this summer to assess barriers to oral health care, as well as satisfaction of dental care for nursing home and homebound aging Iowans. And finally, I will be discussing next steps moving forward and where we're going from here on out. So this is just a brief numbers so we can get an idea of how we are, lay of the land in the state. There's a little over 457,000 estimated Iowans who are 65 and older, about 15% of the population. How that ranks compared to the United States puts us about the seventh in the nation. As these individuals, we move up in age, 75 and up and 85 and up. Iowa ranks a little bit higher, number 4 and number 3. So we have quite a few individuals, and as we know, baby boomer generation, more to come. How that looks in a picture form, the Department on Aging had provided these great graphics. Shows Iowa in the different counties. Any spot that is blue is an area where 20% or more of the county has individuals who are 65 and up. So that's 2 years ago, and where that's projected to grow to 2020, you can see a significant change. Significant change and growth, so that presents some unique challenges. You'll see both rural and metropolitan areas are covered there. I think you can probably guess that this isn't going to be a one-size-fits-all solution. Multiple different projects and efforts are going to help meet this access goal. So, what's important about this? People we know are keeping their teeth longer. It's very rare that I hear at our dental office somebody coming in wanting to get fitted for their dentures at age 30 or even age 50, and that used to be the case so many years ago. Dental IQ has increased. There's been advancements in dentistry such as dental implants. People are understanding the importance and investing in oral health care. Finally, community water fluoridation, of course, has been significant in the last 50 years, helping to increase oral health for everyone across the nation. So Healthy Iowan Goals, there's 3 that specifically relate to individuals who are 65 and older. The first one here is to reduce the population of 65 and older to 20% or fewer that have lost their natural teeth, so edentulous, wearing dentures. In 2010, that number was 16.9%, so we've met that goal at this point. It's a pretty significant decrease since 1999. Of course, we can't stop here. We can always improve that. But I think that's important to note that we've made some progress, at least in the last 10 years. The second one is to increase the proportion of 65 and older who had had a dental exam in the previous years, up to 75%. The number I had to compare that to from the behavior risk information was 72.6. So we're nearing that number, but of course it's important to keep growing it. We don't want to stop at that goal, but keep pushing forward. And finally, we want to increase to 80% the proportion of long-term care facilities and people who provide oral health exams and screenings. And when you read that, it's a bit subjective. Oral health exams might be something that's dental billable versus a screening coming in a look-see. Something that's changed since 2000 and 2010 when these were created and revised, the nursing home assessment, this MDS, and I'll talk a little bit more about that later on, has now included an oral health screening component. So if you are asking nursing homes today, are you screening your patients or your residents, And they're going to all say yes because that's part of that MDS assessment. So in that side, we'll say 100%. If we are looking more towards an oral health professional, such as a hygienist or a dentist, the last survey that the University of Iowa had conducted in 1998 was near 20%, so significant room for growth. So this is just a brief. I know there's a lot of dental folks. I think it's just a quick slide on why we even need to care about oral health. How does it affect residents and homebound individuals and really everyone? Of course, we know that poor oral health affects our entire system. Our mouth is a window to our overall health, is a pretty common saying I'm sure you've heard. Tooth loss and malnutrition, not being able to eat or eat comfortably due to pain, oral health problems, teeth that are loose. Inflammation or lesions due to a prosthetic device, either a partial or a denture. When those sit and rub, think of grabbing a new pair of shoes and running and you get blisters. The same thing happens with dentures as the gums and bones change, especially for someone who's a new denture wearer. Xerostomia or dry mouth. This seems to be huge. There are over 400 medications at least that have a significant side effect of dry mouth. It compromises saliva, our ability to keep our mouth lubricated, neutralize acids, and so on. So it's important to note that, and most of these residents are probably on antipsychotics or anti-Parkinson's medicines, blood pressure medicines. All of these could have a dry mouth side effect. So it's important to know that and reevaluate patients moving forward. Of course, this puts them at greater risk for coronal or root caries, which is right down by your gum line. Root caries, that surface is a little bit softer. Plaque sits on there and isn't cleaned off regularly. Of course, that puts them at greater risk. And as well as self-esteem and social interaction. If we're not feeling good about our mouth, that affects wanting to go out in public or interacting with others. For the nursing home, homebound elderly, we know that these individuals may already have an immunocompromised system. There's strong correlations and causal relations, evidence-based, that suggest poor oral health, the bacteria that is found in our mouth, and how that transmits to systemic infections. We'll hear a little bit more about that from Dr. Stein later on this afternoon. So nearly 70% of us as we grow at 65 and older will require some type of long-term care in the future. The Administration on Aging acknowledges current barriers to accessing care. Of course, costs for oral health care, since so many individuals do not have dental insurance, or they're spending their money on medications or home costs. Fixed income, again. Limited dental insurance, I mentioned before. There is a Humana insurance that can be purchased for Medicare, although it's not required. Transportation and mobility issues, trying to leave the house or leave the nursing facility and make it to the dental office for care. And finally, transition for immigrant older adults. And I see we've seen the last 10, 15 years how Iowa's become more culturally diverse. That's certainly an issue, trying translation and barriers, trying to get the education component to family members, even when there's somebody translating, the importance of oral health care and why you need to be seen by a provider and have routine cleanings and checkups. So who's providing this care for homebound and nursing home providers? Direct care professionals are also known as direct care workers. They are Iowa's largest workforce, and the last estimate was approximately 73,000 of these individuals touch lives every day in Iowa. This includes nurses, home health aides, CNAs, and so on. They provide 70 to 80% of the care in these settings, including personal assistance for seniors. Currently, the Direct Care Workforce Initiative, working with the Iowa Department of Public Health, is developing standards, education standards, and credentialing so that across the board, if we go into Scott County or Webster County, anywhere in Iowa, we'll have the same education standards. Any oral health component that's added should be the same and hopefully not overlooked as they go out to touch lives. One current effort that's going on, and I believe it goes on through next month, is the Nursing Facility Oral Health Education Project, which is through the Iowa Healthcare Association. This is a geriatric oral health care event that goes out to discuss, to help nurses, dental professionals meet with nurses in nursing home facilities to help provide that assessment or screening care, since they are the ones who are routinely doing the initial assessment on nursing home residents. In addition, there's an educational component for nursing home administrations discussing dental public health supervision hygienists, which is a little bit different than your typical hygienist that you'll find in an office. Trying to connect those services so hygienists could go out into these facilities and help provide prophylaxis or cleaning care, as well as some fluoride varnish and just oral exams as well. So this is a real quick, people might already understand this. Medicare, there's very minimal, limited coverage for dental services. It's typically an oral exam or maybe an extraction prior to a major surgery or heart valve replacement or an organ transplant, but not your routine filling, cleaning. Those aren't covered. Again, I had mentioned Humana insurance is a supplement that some people can purchase. Private dental insurance, many individuals in this age group choose to not participate or they lose their insurance benefits as they retire. And Medicaid in this state, it's not this way across the nation, but in our state we do have some dental benefit coverage, some exam fillings, restoration, routine care like that. So that's, I think, a plus. There are some places across the states that only provide emergency care. So in that sense, I think that's nice. So focusing in on the homebound population first, I'll do the homebound and the questionnaire, the nursing home, and the questionnaire for them as well to try to match everything up. Defining the homebound population is somewhat subjective, so I've pulled the Medicare information just for a comparison. So to be considered homebound, the beneficiaries must leave, leaving the home requires considerable and taxing effort. They already have a plan in place with a physician. They're working on maintaining or bettering their health so that they can go out into their environment. They're not leaving every day to go out for lunch with friends. They're not going shopping. These individuals are allowed to leave for an adult day or an adult daycare program, for religious services, doctor's appointments, and then, of course, something like a special function. But typically, they're at home most of the time, and they are in need of skilled nursing care. So assessing these individuals, a case manager goes in, and not just oral health, but all over. Mental health, ability to move around, anything that they might need to help. This OASIS, which is Outcome and Assessment Information Set, is the comprehensive set that's initially used and periodically used to assess these individuals. Currently, there's not an oral health specific section. They do lump a question in about being able to brush teeth, wash your hair, comb your hair, wash your face, but that's basically the only oral health questions surrounding that, maybe in nutrition if the individual has some difficulty swallowing or painful eating. So that might be something in the future. It'd be nice to add in, but of course, difficult. So who's touching these lives? We have local public health service contracts for fiscal year 2012, which ended in June of this year. A little over 18,000 nursing visits. This would be skilled health maintenance promotion going throughout the 99 counties in Iowa. And then a little over 157,000 home health aid hours. This includes chores, homemaker, but it also includes some personal care, so people going in and helping with bathing, brushing teeth. And it's a perfect opportunity to be asking about oral health if there's any pain, just quickly examining the mouth and helping potentially refer to an oral health care provider or connect with a dentist or dental hygienist. So I think this is a great touch point opportunity, and I mentioned earlier the efforts of the Direct Care Professional Initiative and a tie-in with this group. So the Elderly Waiver Program is a subset for Medicare individuals who qualify for Medicare, operated by the area agencies on aging. And this helps coordinate home and community efforts for frail and vulnerable Iowans. There's certainly a financial incentive for all of us to do this, as well as an incentive to keep the resident or the consumer at home. Cost-wise, for case management is a little, $600 to $700 a month, compared to having that same person in a nursing facility that's 35 on up. I thought that was pretty conservative, too, with some of the information I've seen. Nursing home monthly rates go quite a bit higher. Case managers do use a form, this 470, 4694 assessment, with 2 specific oral health questions asking the consumer if they do have a dentist, yes or no, and then if they have any problems that make it difficult to eat, which is in the nutrition section. So let's say somebody says yes to either of these. This prompts the case manager to include it in a crisis intervention plan, but currently they're not required to go out and try to find services for this person. They need to document it. Some case managers are gung-ho, great, they'll try to find that for their individual, but as we know, they're pretty bogged down right now and trying to do the best they can. So what they do is help coordinate with the AAA Iowa associations to help coordinate those services. So I4A, which I'll talk about in a little bit. So for 2011, there was 8,772 individuals who qualified for the elderly waiver. We evaluated Medicaid claims for the homebound elderly waivers last year and found that 74% of these individuals did not have a dental service. So this excludes something like a screening, which wouldn't be considered a dental billable service. So anything else, a cleaning, a fluoride treatment, any radiographs that would be exposed, denture adjustments like that. These individuals, 74% did not receive. How that looks, picture form. So what have we done in the past? There was a homebound care program similar to the iSmiles, which is extremely successful in the state, helping provide care for children. On the Aging Iowans section, there was a pilot program in 2007 that I believe it was 5 or 6 counties utilized home nursing services. Hygienists would go in and train the trainer with nurses to help provide screenings, how to clean prosthetics, how to brush somebody else's teeth, which sounds pretty easy, but it really isn't. It's hard to even floss our own teeth, let alone somebody else's. So imagine having a nurse go out and try to do that in addition to everything else they're supposed to be doing at that home care visit. This was specifically for homebound seniors, and the feedback I had received was that it was well received, and individuals liked that. However, it was discontinued after a few years due to funding, as well as strains placed upon the Oral Health Bureau staff. In addition, there was not a formal evaluation that I could share with you that's taken place. Even though the feedback was good, there wasn't a formal. So the takeaway is that there is still a lot to learn about this population, establishing baselines and moving forward. Next is the questionnaire that we had sent out to the Iowa Association of Area Agencies on Aging. I had mentioned before they work with DHS case managers and the elderly waiver component, trying to help connect services to the homebound individuals. They do tremendous work, everything from transportation to legal assistance, helping finding employment, assistant. And then I've listed some here that could be possible touch points with the oral health world. So adult day services, senior services, congregate meals. All of these, they do try to help connect individuals. There's 13 agencies located throughout Iowa. They do cover all 99 counties. So in this questionnaire, I should preface, it's not a formal study, but just a questionnaire to gather some information. 55 respondents. You'll see the geographic representation, pretty even, maybe a little more from the Northwest. So we first asked, I'm going to call this the I4A, is kind of the shorthand for Iowa Area Association on Aging affiliates. We asked the I4A affiliates if they felt they were easily able to obtain dental services for residents. So this is dental services for a private pay, someone who might have insurance, as well as Medicaid individuals. And 69% said no, they had difficulty. So you have this case manager identifying on a crisis management plan, hey, this person doesn't have a dentist, or that yes, they're having some pain. And then trying to find services is clearly a difficulty for this group. Then we narrow this down to specific Medicaid individuals and ask them to evaluate the following statement on a Likert scale: strongly to agree to strongly disagree. Staff can always find a dentist to treat Medicaid patients when needed. And 63% either disagreed or strongly disagreed with this statement. Again, feedback is that a lot of dentists are either not taking new Medicaid patients or are not taking any at all. So we asked a series of barriers to oral health, and had them again rate that on a Likert scale: strongly agree through strongly to disagree. And bear with me on the slide, it's a little overwhelming at first. Instead of giving you lots and lots of numbers, I thought a picture might show this a little bit better. So you're going to see the breakdown in percent. The strongly agree is dark green, the light green is agree. So financial constraints of the client, the majority of individuals felt that this was an issue. The dentist's preference to treat at the own office, where they'd prefer to have a patient or a resident come in to see them, or a homebound elderly. And transporting a client to the dental office presents some unique challenges. You really need to rely on a family member or a transportation service connected through the AAA or the I4A to help get that individual there. And then lastly, this family member lack of understanding the importance of obtaining oral health care. You think about the family members are a strong advocate for their aging Iowan too, and if they're not caring that much about their oral health, or they aren't visiting the dentist themselves, why are they going to be promoting that for their parent or their loved ones? So I think that's a great education component as well, not only speaking to the consumer or the resident nursing home, but also the family members, and really helping to make that connection and understand that just because mom or dad or friend isn't having pain, they still need to seek out care. Moving on to the nursing home population. This is a quick number: 442 certified numbers. That varies by 1 or 2 depending on the source for last year, and 32,000, a little over 32,000 beds. The breakdown, a good mix of Medicare and Medicaid participation, as well as dual participants. So as of the end of June, there was 24,309 approximate residents in the nursing facility. Occupancy rating is 74.7%. Comparing that to the overall U.S., we're a little bit lower. So occupancy ratings are going to come into play. We want to keep our residents healthy, but there's also a financial advantage in how nursing homes get paid, especially for Medicaid. So we're going to learn a little bit later about the importance of keeping residents healthy and how that can affect payment through a bed hold policy. Dr. Stein will discuss that a little bit more in her presentation. Just a brief overview. In 1987, the Omnibus Budget Reconciliation Act required that there'd be a dental or a dentist associated with each nursing home and to help provide emergency care if needed. So there's somebody connected. It doesn't say that they need to come in and perform exams or provide care. It just needs to have one connected for emergency services. Currently, nurse health coordinators are the ones who complete the initial oral health assessment as part of the minimum data set, this MDS sheet. 40 pages, I think, a thick book of questions that's time-consuming. Oral health is just one of many sections. So mental health, just nutrition, everything is covered. And as of 2010, we do have this oral health section, which is fantastic. The initial MDS assessment is completed within 14 days, and then periodic reassessments, which when they go and they cover, it's called a 7-day look back, where they ask these questions and relate them to the past week. Just to clarify that the MDS is not considered an oral health exam that would be billable, and on those, the information that I show you next isn't included as a dental service. So I'm not sure if this is easy to see or not. I can just briefly read these off. These are the MDS questions from Section L. The first is broken or loosely fitting denture or partial, no teeth or tooth fragments, abnormal mouth tissue, obvious or likely cavity or broken natural teeth, inflamed or bleeding gums, mouth or facial pain, discomfort or difficulty chewing, which is a tie-in to the nutrition section, unable to examine, and then none of the above were present. So let's say somebody you find has a broken denture. They go in, the nurse case manager, or the MDS coordinator, sees this. It's called a care area assessment, so a triggered response. If somebody check marks that first one, it requires action to help that individual seek treatment for a new denture, either to have a dentist come in, help provide transportation to go out to a dentist as well. So when we looked at MDS data from the Centers of Medicare and Medicaid, CMS data, includes both of these residents. I pulled the report, although the third quarter is out, just to try to keep everything on an even playing field with the previous information I provided. I pulled the one of June of this year. Approximately 24,077 residents, which is similar to the previous number. So 25% of these individuals reported one or more of the dental events. And the dental events, of course, are these first 6 that are listed here that I named off. 25% had one of these events. And then 7.3, or a little over 1,700, had a likely cavity or a broken natural tooth. Now keep in mind, we're not exposing radiographs, might not have a light and a mirror, just visually inspecting, seeing broken teeth or root caries to report this. So this could be significantly higher, of course, if we had radiographs and other diagnostic measures. And then finally, for broken or loose fitting denture or partial, 2.5%, almost 600 individuals. This is important because it's a little bit higher than our national average. All the other ones we seem to be pretty similar, but this one was a little bit higher. I think it's interesting to note for dentures and partials, oftentimes a loose-fitting partial can be better just by tightening a clasp. And I think for the dental folks out here, you know how easy it is to make someone's day by having their nice flapping partial, just tighten it. The same thing with dentures, sometimes it's a simple reline. And to have these people go for months with moving dentures causing lesions is just so uncomfortable. So again, we looked at claims for 65 over. When I say non-waiver medical eligibles, I'm excluding those elderly waiver that I had discussed before. This is including nursing home individuals, but for this particular one, it also includes individuals who might live at their home with their family, so just one big group shot. 84% of these individuals had not had a dental service in 2011. Again, that excludes any screening component. So it's 29. Again, you'll see that number's a little bit higher than the nursing home because it does include a few others. But then when I thought about this and I thought, well, what about people who are going in for a hip replacement or rehab and they're only in for 3 months? Is that going to affect numbers at all? Are they going to leave and go back to their regular dentist? So when we specified Medicaid eligibles who are in a nursing facility or in an intermediate care facility for intellectually disabled individuals 65 and over, the data kind of lumps that together. For greater than 6 months, perfect time for in-between prophies as well. 85% of these still, so the number was still pretty high, had not received a dental service in 2011. This is just, for both areas, just tremendous room for growth, I think, and I think you guys probably would agree. So then the second portion is this access to care questionnaire for nursing home and long-term care facilities. We sent this questionnaire out to 170 responded for nursing home administrators, directors of nursing, healthcare aides, as well as nurses. The demographics, the overwhelming were from nursing care facilities, although there were some that were combined nursing home and assisted living facilities, and then just a few that were solely assisted living. Again, equal graphic representation. These numbers were pretty close. So a similar question that we asked the Homebound, we asked nonprofit and private nursing home, long-term care facilities, if they were easily able to obtain dental services, meaning Medicaid dental services, private pay, or insurance. And 46% said no. So you'll see this is a little bit less than the other group, but still not a great number. 46 is almost halfway there. So that's a little bit troubling to me, and I think probably to the rest of everyone in this room too. We then specifically asked the Medicaid question, nursing home long-term care respondents, to evaluate the following statement: if staff were easily able to find a dentist to treat a Medicaid patient when needed. And again, 59% were strongly agree, or disagree, or strongly disagree. So what were some of these barriers that they felt? Part of this were questions, some were open-ended questions as well. Barriers to obtaining dental service in nursing facilities. The preference to treat at the dental office or transport the resident. So this could be perceived by the nursing homes themselves, or feedback that they had received from the dentist, that maybe the dentist doesn't want to come in because they'd prefer to treat at their own office where it's a comfortable surrounding for them. Insufficient space and equipment within the care facility, which we'll learn in a couple models today, shouldn't really count. You can take a very small space and turn it into an effective kind of dental operatory with really just minimal space, a plug-in, and a water source. But that was defined either perceived or feedback from dentists. And then providing care to residents with behavior difficulties. As we know, for some Alzheimer's dementia patients, every day could be completely different. So removing these individuals from their normal surroundings might trigger just an uncomfortable experience. They might not want to be positioned in a dental operatory. Leaving the facility, weather starts to be a problem. All of this contributes. Again, financial constraints of residents has come up again as a barrier. And then finally, the interest and willingness of dental health professionals to work in a nursing home or a long-term care facility. This is either from feedback from dentists or nursing home administrations perceive this as well. So I think it's important to acknowledge an IDA effort or initiative that was in 1995 where they sent out a survey to all nursing homes in Iowa and received, I think, about a 30% response rate, asking who was in need of a dentist and trying to help connect a dentist to each facility. So of those who responded, they were successful in helping identify a nursing home and then a dentist to go with that nursing home. This also complements the dentists and hygienists in the room are probably going, hey, why didn't anybody ask me? Because I'm covering this. Everyone's going, you didn't ask me about this. But there's been a recent, more formal survey by the University of Iowa that came out last year. Dr. Ettinger-Chalmers, there's a couple other dentists who had surveyed nursing home directors as well as dentists. And a lot of these complement the findings that dentists were very busy in their practice and didn't have time, or again, they'd prefer to care in their own facility. So I think that's worth mentioning. That's actually very new. I think that was just this last 2011, January was when that article came out, or journal article. When it comes to those who provided services other than oral hygiene care, dentists were identified, 72%, as the primary provider of dental services, second to dental hygienists. And then 18% of these individuals had reported the use of portable dental equipment in the facility. And it is probably no surprise the people who had reported use of dental portable equipment in their facility were extremely happy and able to find services. That kind of makes sense. But those lined up when we were looking at the results. And then during the last 12 months, 37% of nursing home long-term facilities reported having an oral health professional provide some dental service in their facility. So we asked that, and then we said, what service was provided? So these are based on the percentage of the respondents. You'll see the first three are significant: staff education, screening, and referrals to outside dental or dentist or a specialist, which is all great, especially staff education. I think that's significantly important. You'll see when it comes to restorative, preventive, and emergency care that is far less So we can go in and screen and we can refer, but actually providing that care or providing cleanings, there's definitely room for growth in this area, as we know. So again, we asked a series of questions and asked individuals to rank them on the strongly agree to strongly disagree, and was broken down by the percentage of respondents. The nursing home staff was responsible for daily oral hygiene and that brushing should be a part of their daily routine. Overwhelming agree, or strongly agree and agree. And then just a little bit less, but the majority agree with the following statements: that oral exams should be performed by a dentist once a year for those who are wearing dentures, as well as residents should have their teeth cleaned twice a year. And lastly, residents having an established dental provider. You can see this breaks down a little bit more. There's quite a few more that disagree with that statement. This could also just be a dentist that they grew up with, that they were used to going to and still go to, not relying on somebody to come to their nursing facility. Finally, the resident was regularly evaluated on his or her ability to brush their own teeth, which is important because as individuals progress or digress, we need to reevaluate those periodically, and I think the MDS is part of that assessment as well, so I wasn't surprised to see the agree or strongly agree. And that the facility provides in-service training for staff on oral health care. Strongly agree. Many of these facilities are doing that, which is great. So for people who are not having a dentist or a hygienist come in to provide care, how else can these individuals access care? The most common and that I see in the office I work for is that a relative or a friend provide transportation to the dental office. And this is fantastic for those who can take time off work and really can devote time to bringing a friend or a parent. But that's not always the case. And if you live somewhere outside of the state, that becomes a barrier to relying on others to help care. We can't always assume that there's a family member living nearby. Sometimes the care facility does provide this transportation. The downside of that is that an oral health, or a health aide needs to travel along with the resident. That takes time away from other residents that they may be caring for and is an additional cost to the facility. And finally, perhaps the resident is just not receiving routine health care, oral health care. And they might perceive their own oral health status to be fine. Again, this isn't an age thing in this regard. How many people, any age, come in and say, well, nothing hurts, I'm fine. You don't need to do that. I don't feel my cavities, so it doesn't need to be filled. Can we just watch it? I'm sure that's common for the dentists in the group. Residents' right to deny or withdraw consent. You can't make somebody have an oral exam, so if they're not going to want one, perhaps they're just going to forego that too and let things go downhill if need be. And finally, the family member or the guardian does not want to cause fear or distress for their loved one. And this is huge. Again, this kind of ties into how that family member perceives their own oral health. If they're actively going to the dentist twice a year, if they're not doing that and they're kind of a monitor, put out the fire type of person, why are they going to advocate for their parent if they're not in pain? And everyone thinks the dentists are evil, so it hurts to go to the dentist. I don't want my teeth cleaned. So why are they going to say, sure, clean mom or dad's teeth, or sure, look? They're going to think, no, don't do anything until it hurts. Not everyone, but that could be the case for some. All right, and lastly, moving forward. Where are we going from here and moving forward in the future? I think there's some great things to highlight. We have assessment forms. The MDS section, adding that oral health section is just huge in my mind because it wasn't there before. And we'll also focus, I guess, on what's happening in Iowa. What's happening here locally that's successful, and how can we shrink that change for others and copy successes, focus on successes. Just a couple of the bright spots. I mentioned before this Omnibus Reconciliation Act that connected dentists to nursing facilities as an emergency. I think this is a great place to start and to have that conversation, the nursing home administrator with the dentist. Are they actively participating in the care of the nursing facility? Are they simply a name on a paper? Are they wanting to come in and provide education for the healthcare direct care providers and nurses? Or are they just there? If they're not there, maybe it's an opportunity to go out and seek out somebody who is willing to come in and provide care in addition to being that dentist of record. Finally, I mentioned before the oral health screening component in MDS 3.0. That was released in the fall of 2010. So prior to that, there weren't a specific oral health section. So I think that's still new enough and trying to really help connect oral health, the importance and examinations for the MDS coordinators. That's still pretty new, and I think we're doing a good job. I mentioned the other program through the Iowa Health Association that's helping the educational component there as well. We are so fortunate to have this wonderful geriatric and special needs education program at the university. This has been around for quite a while, but this really helps shrink the change. If you're used to sitting in your typical operatory, and the thought of going out into a nursing home or someone's personal home is just scary. It's not your own environment. Sometimes switching rooms and working out of a separate room causes anxiety. You're just used to your stuff the way it is. So graduates of this program are going through this training. They're going through the mobile health care unit. They're going out to the nursing homes, and they're having this experience. So when they graduate and they leave, they're not sitting there saying, I don't know if I want to do that because fear of the unknown is scary. They've been there. So it really does help shrink the change and provide a good opportunity to connect these dentists with nursing home facilities and Homebound as well. And finally, this is also a newer change, 2007, the public health supervision hygienist. We commonly think of those individuals on the pediatric side going into Head Start programs or daycares and providing oral health assessments, fluoride treatments, and it's been extremely successful. In 2007, nursing facilities were added to that and approved for that, so I think that's a great opportunity for hygienists to go out and do the prevention. I believe they're allowed to do everything except for administer anesthetic and nitrous. So a little bit more about the public health supervision hygienists. They're able to provide screenings and prevention services. They contract with the dentist, but don't necessarily work for that dentist or under that dentist. They don't go back to their office to work, but they contract with them. You need at least 3 years experience. And then you're required to submit annual reports to the Iowa Department of Public Health stating how many individuals did you care for and what types of services were performed. For others who are not currently a public health supervision hygienist, actually I should back up a little bit. The ADHA has a great toolkit. I think Mary Kelly helped put that together. It's a great toolkit with more information on how to contract, how to get licensing for that, and how to find a dentist to really help with that. So it's just a fantastic resource that's on their website, and I think also connected to the Iowa Dental Hygienists Association website. Finally, general supervision. So for everybody who is currently working in a dental office, typical what we think of hygiene, you can still help in this environment. It's general supervision just like it would be at work. So a local dentist needs to go in and examine the patient or the resident before you go in and treat. And finally, the existing successful mobile health clinic models. I'm mentioning 2, but I know that there are many more, and sometimes we don't know about them because people are going out on their own with their nice little toolbox and going out into the world and helping, and then they don't come back and tell anyone, which is okay. But 2 of them that I'm going to highlight today are the mobile health dental clinics in Atlantic and Iowa City. We're going to hear from Dan March and Dr. Cowan later on a little more extensively. But these are great models that go out into rural communities, go out into the nursing facilities and help provide this care. And just great feedback from the nursing home administrators as well as the residents and the family members because they're receiving this care. They don't have to worry about it. The nursing home administrators aren't sitting there thinking, I can't find somebody to take my residents. So with that, the rest of the morning is really going to focus on these nationwide programs that are successful models. And the afternoon is going to focus in on more local, this Atlantic model and the Iowa City model, and hopefully energize everyone and get everyone on keep wanting to move forward with us. So thank you all for your time. Are there any questions that you have? You know, you want to turn? I think we need to probably hit, there's a red button on that mic to help turn it on.
Hello? Yes. All right. I was wondering if you had any information on the dental hygiene programs and their experiences include visiting nursing homes in their externships?
I am not sure about that, but I'd be happy to look it up and get back to you. I know there's quite a few hygiene. Maybe Deb Penny is in the audience. She might be able to better answer that question for me. Is there an oral, a geriatric component to the hygiene where they're going out into nursing facilities as well? Sorry, thanks. I put you on the spot. Nope, we all learn together.
Yes, actually they do. They go out into the nursing homes and they do an instructional component. It's usually with the CNAs. We only have 21 students that go out, so we don't serve that many. But I think it's a good service. I think the students are extremely surprised to find out that they're starting at ground level, ground zero, that there's hardly any knowledge at all. The biggest thing that they find is that the care providers are not even really well-versed in caring for their own mouths. Mm-hmm. And many times the recipients are more interested in how they can care for their own mouths than how they're going to take that to the residents. So just a little bit of information there. No facts and figures.
No, that actually complements some information I think we're going to hear later on from Dr. Stein, too. I had heard that. Thank you for sharing that. I appreciate that. Anyone else? Nobody likes the mic. It's okay.
In my experience, when I was a hygiene student and I was out in the nursing home environment and I was doing instructions to the CNAs, to staff, and doing everything I could to give them my knowledge, what I was so disappointed in is when I was giving this talk and being so instructional and so informative, the lack of care from the CNAs. They were just, I kind of felt my time was useless. So I don't know how do you get the CNAs to listen, and they were made to come, and I tried to make it interesting, I tried to make it applicable. And that's what I came home, came back to school, and I was so disheartened about, because they weren't listening, they couldn't make eye contact, nothing was going in, Anyway, that's my 2 cents worth. That's speaking from my experience.
So part of that is creatively framing it so that it's both interesting to the healthcare provider and the healthcare aide.
This was a very large facility. They even asked me to come back and another day and give the same talk on another floor. And I got the same thing. It was just, it's frustrating. Anyway, I don't know. How do you promote the care? And this is a true need, and this is important. And
I think part of it is comfort level for these people. I've been involved with training and nurses as well as CNAs, and the nurses and CNAs do not really like the mouth. They would much rather deal with the other end. I've been involved and watched them look at slides, and I'm looking at slides with all this oral pathology, just having a good old time, and they're just like this. And then they get to the thing that's an oral thing that has eye complications, and they start showing the eyes, and the nurses are all, wow, look at those eyes. And I'm like, oh, I can't look at the eyes. It's our comfort level. And I think we're really kind of fighting a losing battle here. I don't think it hurts to try, but I think that we have to understand that CNAs do not get very much money. They are very overworked, and that maybe we do really need to look at a different professional to provide these services.
I think you touched on that.
Especially with the cost of aspiration pneumonia, you could pay a hygienist to be at the care facility if you just prevented 1 or 2 cases.
I think you touched on a great...
Yay, Sue. I'm from Iowa Central, and our students do a rotation every Wednesday at the nursing home. Great. And we do screenings and oral hygiene instruction. We also do education. I think it's been a great partnership. We've been doing this for about 7 years now, and it seems like it's working, and we're continuing to do so. But I also agree that I'm not quite sure why we feel we need to take time to train others when we have an adequate supply of people who know exactly what to do, and they should be providing that care. Thank you.
Thank you. Thank you guys all for your question. Thanks for helping provide some of the education component as well. I think I'm going to try to switch this computer over for our next speaker, and thank you so much for your time and attention. I appreciate that.